So my task this evening is, it's about a topic which is quite new. It's like, in the future gynecologists should know, well, everything about adenomyosis, but there is still a lack of about that. That's why in the first slide I've put an histology picture, and next to it an ultrasound scan of an adenomyotic uterus. This is why, just because every day I'm using an ultrasound machine, so my second expertise is in ultrasound, so that's why I'm scanning all the patient. And the adenomyosis, I think it's the best disease to interpret this change from the histology to the imaging. Let's see if I can't. Okay, it's quite difficult to change slides. I don't know why it's so slow. Everyone knows that the definition of adenomyosis comes from the books of histology. So adenomyosis has the migration of endometrial glands and stroma deep in the myometrium. And this is associated also to an hyperplasia of smooth muscle. And normally we think to the adenomyotic patient as a patient with dysmenorrhea, dyspareunia, heavy menstrual bleeding, or infertility. However, we think that these are the most important pathogenetic mechanisms, and we see that there are many similarities with endometriosis, because we can find aberration in sex steroid receptors, inflammation, neuroangiogenesis, proliferation and fibrosis. And all these pathogenic factors can explain all the symptoms that women usually present. These are all the theories about the pathogenesis, and there is still no clarity about that. So unfortunately, I won't give you all the answer about adenomyosis, because many things are still ongoing. And about the pathogenesis, we have the most acknowledged theory, which is based on the invasion from the endometrium. But there is also another theory based on the stem cell, and the other one is the invasion from the outside, which is the phenotype of adenomyosis, which is very linked to the endometriosis. If we see the first one, so the invasion from the endometrium, the adenomyosis develops through the downgrowth and the invagination of the endometrium basalis and go through an altered or absent junctional zone. We will see later the concept related to the junctional zone, which is actually not an histology concept, is something related to ultrasound and MRI. So there is nothing in the histology. We can't actually find something which can be called junctional zone in the histology. So we can have the diffuse adenomyosis, and we have the theory from inside to outside invasion. And one of the main important mechanisms to cause these traumatism to the level of the endometrium is the autotraumatization and the mechanism of tissue injury and repair. About the stem cell, these adult endometrial stem cell may be displaced into the myometrium after the menstruation. And here we have the theory by Chaperon, from where there is a typical specific phenotype of adenomyosis, focal adenomyosis of the outer myometrium, where the endometriotic cells migrates into the myometrium. So this is exactly the opposite, the from outside to inside invasion. But again, we still don't have a final theory like actually in the endometriosis. About the stem cell theory, we think that the embryonic or adult stem cell may undergo metaplasia into the myometrium and creating an adenotic foci. So Adenomyosis, is this a disease? This is something, it's, you know, quite an unusual question, but it's something new because for the first time, adenomyosis has the authority to be considered a disease when it was included in the Palm Coin. So we can consider adenomyosis as a disease per se. Why I'm saying that? Because in the past, we thought to adenomyosis as the typical disease to perimenopausal women with heavy menstrual bleeding who underwent to an hysterectomy, and the diagnosis was only done by the pathologist, so by histology. What about the epidemiology? We know from this last publication in 2020 that the adenomyosis burden is very high, not only for women, for their quality of life, but also for the healthcare system. Unfortunately, we don't have the population-based data on incidence, and this is due mostly on the problems related with diagnosis. If we see the prevalence is very different, from 5% to 70%, and is different according to different population, different region, or different diagnostic criteria. So that's why diagnosis is so important. If we see the thing we consider the most reliable, like the histology, you see that we have a different percentage from 10% to 88% among different pathologies, analyzing exactly the same specimen. So even for the histology criteria, this is not very reliable. It was very so that's why for the SEUD, which is the Society for Endometriosis and Uterine Disorders, which I'm part of, we decided to work deeply on the diagnosis of adenomyosis. So we had this great change from histology to the role of imaging. That's why we will talk about imaging. And that's the paper they were referring to, where we have tried to review all the diagnostic criteria, all the threshold, all the issues related to diagnosis of adenomyosis. So the first thing is questioning. So we try to build a flow chart, and the history, it's very, very important. Then the symptoms, we will see each one, and then clinical sign, but very, very important, the imaging. So the epidemiology, we know it's very different even compared with age. That's something new, the novelty. So we found in a paper we published in 2015 that in a group of very young patients, they were age 18, 30 years old, and they were coming to our clinic just for a consultation for contraception. And they had no, I mean, they don't think to have any symptoms. And when we look at their uterus by ultrasound, we found that the 34% of ultrasound sign of diffuse adenomyosis, while the more or less the same percentage we found with MRI. So that's the completely change from age 35, 50 years to the young age and the nulliparity. That's why it's so important to remember that adenomyosis is something to bear in mind if you are dealing with a patient with infertility or fertility issues. So the abnormal uterine bleeding is the most common symptom, even though I would say that this is the typical symptom of the adenomyosis we refer in the multiparous women. Then the pain, then the infertility or recurrent miscarriage. But don't forget that 30% of women are completely asymptomatic. So we can find adenomyosis only because we are doing an ultrasound, we are doing an MRI for other reason, maybe for endometriosis. and we find out that there is also adenomyosis. Regarding symptoms, again, very controversial results. We say here we have women undergoing hysterectomy, 33% with IUB, 60% in women undergoing ultrasound, heavy menstrual bleeding, while we have a completely different figures in young women. And even for dysmenorrhea, for dyspareunia or pelvic pain, you see that the figures are very, very complicated. So everything is quite confusing. So let's go to what we have to look for while we are doing our ultrasound. The thing we have to refer to is the Musa consensus. So the usual criteria for ultrasound assessment of adenomyosis. These describes the ultrasound features, the typical ultrasound features of adenomyosis. Let's see the first criteria. So here you see two different uterus, and both have a different symmetry of the uterine wall. So you see that in this case, for example, you have a thickening of the posterior wall of the uterus compared to the anterior one. So this one is one of the first signs we usually find in adenomyosis. Another typical factor, another typical appearance is the presence of myometrial cyst. You see these round images with an apoechoic halo. These are typical myometrial cysts. And if you put the power Doppler on, you can recognize if they are really myometrial cysts or they are vascular vessels. Another typical feature is the presence of hyperechoic island. These looks like trees, very white, so very hyperechoic, because this comes from the endometrium. If you see, this is the endometrium, and from somewhere, some endometrial cells go into the myometrium, and the appearance we have in the ultrasound scan, it's an hyperechoic island. Another typical feature is the fan-shaped shadowing. This typical appearance, which impair a bit our visualization ultrasound. Next one is the presence, like the hyperechoic islands we have discussed before, the presence of echogenic subendometrial lines or buds, like that one. Again, this is a proof of migration of endometrial cells from the uterine cavity into the myometrium. And last one, the vascularization. So if we put the power Doppler on the uterus, we can find a very high color score and a typical translesional flow. So usually we would have a normal vascularization which is parallel to the uterine cavity. In case of adenomyosis, we have a translesional flow. So you see how vascularized are all these uterus. Then let's move to the junctional zone. We have mentioned before, here is a 3D evaluation of a uterus. And when we talk about junctional zone, we refer to this dark halo around the uterine cavity. So this is the myometrium, here the endometrium, and this one, like here you can see maybe better in another 3D I've done a few days ago. Again, this one is the junctional zone. And there is a specific way to measure it, because we can measure it, the maximum junctional zone, as explained here, and then make the ratio between the myometrial wall, so the this measurement, compared to the junctional zone maximum diameter. And again, the ISUOC helps us in identifying which are the irregular or interrupted or undefined zone to make a diagnosis of adenomyosis. Here you see the junctional zone is very regular. Again, here we have loss of continuity in the junctional zone. Again, here we can see hyperechoic buds or lines just above the junctional zone. So we will use direct signs of infiltration like lines, buds, hyperechoic island, or intramyometrial cyst. Then what we will have as an indirect sign would be a globular, a huge, a big globular uterus. And again, the group of EJUG has helped us in differentiating the various types of adenomyosis, but there is still many controversies on this topic. So the pattern the pathway we should follow would be: is there any adenomyosis in this uterus? Where is this adenomyosis I can see, in which location? And then define the phenotype, if it's a focal localization or if it's a diffuse localization. Then identifying if there are cysts inside the lesion, so if it's a cystic or non-cystic adenomyosis, and then the involvement of the layer according to where if is involved the outer myometrium, the middle myometrium, or just the junctional zone. And again, express ourselves in our subjective evaluation if this adenomyosis, in our opinion, is mild, moderate, or severe. And we can use like the percentage of myometrium involved. But again, this is a proposal. So they've just proposed, and there's still no just few paper on that, because all the features I've shown you, we actually don't know which is the meaning. So we don't know if the presence of the myometrial cyst is different from the presence of coic island in terms of symptoms. So maybe at some point, and there are studies ongoing on that topic, we would know that people who have uterus with intramyometrial cyst, for example, they would have more frequently abnormal uterine bleeding or heavy menstrual bleeding, whereas people with hyperechoic island, maybe I'm just imagining, they're having more pain. So we actually still don't know. What about magnetic resonance? Again, I'm showing you lots of pictures just to get an idea. We have diffuse and nodular adenomyosis, and the sensitivity and the specificity of this technique is very high. The accuracy is 85–95%. And again, I can show you some picture of people I have scanned, and then the radiologist has done the MRI. Here you see the uterus, and you can see the thickening of the junctional zone. Again, this dark yellow. And the junctional zone is more than 12 millimeters. The other criteria in MRI is the ratio between the junctional zone and the total myometrium, more than 40%. Another example of this is a massive adenomyosis, severe adenomyosis in the anterior uterine wall. And here you can see the thickening of the junctional zone, which is absolutely very, the depth is really high. Then we can have some myometrial cysts, which are the ectopic endometrium. Another example here, by using T1 weighted images of adenomyosis, we can find some high signal intensity foci, which are areas of hemorrhage. So this is actually a proof of bleeding into the myometrium. And this is the same example we can do in the ovaries. By checking ultrasound, by checking by MRI the ovaries, we can find also very, very small endometriotic lesions into the ovary. Again, another very severe adenomyosis, but here we can have also, and I can show you another case, the next one. Here we have an anterior focal adenomyosis of the outer myometrium, but here you see there is a lesion into the bladder caused by the endometriosis. So this is an endometriosis bladder nodule, and next to him we can find the anterior focal adenomyosis. Same thing on another slide. Again, here we have a posterior focal adenomyosis of the outer myometrium and a bowel here, where you can see the star, the big star, the bowel endometriosis nodule, and another small nodule at the torus. So again, we can see how endometriosis and adenomyosis are very, very frequently associated. So I've shown you many ways of diagnosing adenomyosis. We have 9 histological classification, 2 ultrasound classification, 7 MRI classification, but again, no one agreed to the other one, to the only one to use. So we still have inconsistency in definition by histology, and no system accepted of image-based reporting or classification of adenomyotic lesions. Another thing to talk about, the coexistence of adenomyosis and uterine fibroid. Here you can see a small fibroid which make an impact on the uterine cavity, and adenomyosis. And again, here in another picture, we can see plenty of fibroid, and next to it, adenomyosis. In those cases, abnormal uterine bleeding, and especially heavy menstrual bleeding, is really, really in a high percentage of cases, like half patients have heavy menstrual bleeding, and even pain, so menstrual pain or pain at sex, it's quite higher than when adenomyosis is alone. So if we look at the ultrasound reports, we can find a 22% coexistence of adenomyosis and uterine fibroids. And why, when we look at the histology specimen, we find a roughly 20% coexistence of both diseases. Considering endometriosis, the figures are 20% in one of the first publication in women undergoing surgery for endometriosis. In our previous work, we found that roughly half patients with deep endometriosis who underwent surgery had adenomyosis, and this was influencing the pre- and post-surgical dysmenorrhea. So what does it mean? It means that after surgery, those who had also adenomyosis had more or less the same pain scores. That's to, this is to prove that even though we remove endometriotic lesions, if adenomyosis is still there, and of course the uterus is still there, maybe the patient would still have pain. So just exactly the opposite concept. When we have endometriosis, think to adenomyosis. When we have adenomyosis, check if deep endometriosis is associated. And this is very important in people who had very, very high pain scores. What about infertility? Just a few words, just at the end of the presentation. So many reasons are at the basis of the link between adenomyosis and infertility. First of all, an abnormal endometrial function. So the local estrogen production, decreased apoptosis, and oxidative stress, which is increased, the progesterone resistance we have talked about before, and also the anatomical distortion of the uterine cavity and the abnormal contractility of the uterus all contribute to an altered uterine receptivity and infertility. What about the figures about adenomyosis and infertility? The prevalence in women undergoing ART are around 20%, according to this paper. And we know that this involves an impact on the pregnancy rate and on the miscarriage rate. But just to make a relationship, so make a connection on what I have said before, what the group of Benaya, which is a group in Milan, in Italy, has found that the implantation in a group of women who undergoing in IVF and diagnosed with adenomyosis, but with no symptoms, have the same pregnancy rate of people without adenomyosis. On the contrary, in another paper, these are both very, very recent, it was shown that the severity of condition, the severity of adenomyosis, as expressed by the number of ultrasound features found during the examination, worsens the reproductive outcome. So the probability of pregnancy rate decreased from 42% in women without adenomyosis to 22% in those with 4 criteria of adenomyosis, the ones I've shown you earlier, to 13% in those who had all the 7 ultrasound features shown by ISUOG. So this makes us thinking about the importance also to the ultrasound criteria and what we can find during imaging assessment to help us in our IVF pathway. And just the last slide to again talk about the association between adenomyosis and endometriosis after surgery for deep endometriosis, especially colorectal endometriosis. We know that if we have an association between adenomyosis and deep lesions, we have the 68% reduction in the likelihood of pregnancy. So again, in all patients with endometriosis, please check the uterus and make screening for adenomyosis, because we would identify probably a subgroup of patients with a worse prognosis, and in this patient maybe the surgery would have an effect which is not so good like in the others. That's good. Okay.